I was looking up some information before we got started, and there's actually a research report by Morningstar that said folks that turn 65 today have a 52% chance of needing long-term care or some type of assistance in their lifetime. It's pretty significant. So as that number creeps up, we want to be thinking about these things. I thought I would might be beneficial to start with a story, because this is something that's actually happened relatively recently, and actually a client that Jan's been working with. So our client is 94 years old.
You're gonna get that back.
Our client is 94 years old, and she has been in assisted living for the past 2 years. Now, the daughters, she has 2 daughters, and they have been primarily running her care, making sure that she gets the care she needs, that she heads into the right places. And it's been taking quite a toll on the daughters, as you can imagine, juggling their responsibilities, plus making sure that mom's taken care of. So they came to us and said, listen, mom's been in assisted care, these expenses are racking up. She's also reaching a point now where we might think she needs to be moved into memory care, right, for let's just say another 2 years. So not only are we dealing with the expenses right now of mom being in assisted living, the stress that it's putting on the daughters, but now we're also dealing with the fact that mom might need to move into memory care, which is more money. So we had the task of sitting down with the daughters and developing a plan that would work for them. So their 3 goals were, maintaining a stable and systematic cash flow to pay for all these things, working through contingencies. So what would this actually look like if mom does go into memory care? Is this going to completely blow up the financial plan, or the things that we can work around? And then thirdly, giving them the peace of mind that they needed to be able to handle their daily responsibilities while also still helping mom. I won't bore you with all the details of the weeks and months long of progress going back and forth, but ultimately we did develop a plan that gave those daughters a peace of mind, knowing that, okay, mom's income plan has now been met. We were juggling things like Social Security, different annuity sources, rental income, portfolio assets, making sure all those things were aligned in a tax efficient way. And then ultimately we were able to create that plan for mom, making sure they saw, okay, if mom goes into health, goes into memory care, here's how that'll look. We need to tweak some of it to make this work. So we're experts in financial planning and investment management. We're here to make sure that you make an impact with your wealth. But as you all know, you can't be an expert in everything. And so that's why I rely upon experts like Susan and her team at One Life Care to make sure that we can bring in those resources so that you guys are all well equipped. Now, what you'll walk away from today is being more educated in the types of services that are available to you and the different level of care and how you can access those programs. Okay. So with that said, I'd like to introduce Susan, and she'll kick us off.
Hello, everyone. Thank you for having me today. I always appreciate opportunities where I can talk to folks about future planning. Why is that? Because I started my career as a hospital social worker and worked on the stroke and general rehab unit in an acute rehab hospital. And sadly, many people who I worked with did not do future planning. Some of them were younger people who had strokes sort of unexpectedly because they had hypertension they didn't know about. But other times people just didn't know that something like this could alter the course of their life, financially, in terms of their family, in terms of their housing situation. And so even at an early point in my career, I realized that one of my missions in life is to really help people think ahead, think about what could happen, and prepare so that they can have peace of mind and that their families can also have peace of mind and comfort knowing that when it's time to put plans into place that they're doing what their loved one wanted them to do. So we'll talk a little bit more about that as we go along. I'm going to do this fancy swipe now. How cool is that? Huh? I'm going to take this with me Is that okay? So just to tell you a little bit about me and our company, my name is Susan Belloff. I'm a licensed clinical social worker. I am a certified aging life care manager and a certified dementia practitioner. So if you know of any other initials that I should have, let me know, because I'm always interested in having more. And I'm part owner of a company here. We are a locally owned company. I'm one of the owners of the business. And we provide several services for older and disabled adults and their families. That includes care management, which we'll talk about throughout this presentation, short-term consultation. This is for families who are maybe in a crisis and just kind of need a roadmap that they want to execute going forward. In-home caregiving. We have a staff of over 100 caregivers who are our direct employees and work with clients who need 4 hours of help every 2 weeks, all the way to 24-hour care 7 days a week. And we also provide assistance with what's called placement consultation, which basically means if you're thinking about moving into a retirement community or some kind of long-term care group living, we help you narrow down the options so that you don't feel adrift in the sea without, some direction as to where to start according to your priorities. I want to introduce Katie Powers in the back of the room. She's our Director of Business Development. Katie and I are happy to talk to you after the presentation if you have a specific question pertaining to yourself or your family. We are filming today on YouTube, so that's what the camera is doing here. So just be aware of that. If there's anything that you would want to keep on a personal level, we're all available afterwards. An aging life care manager is also called a geriatric care manager. Has anyone heard that term before? Okay, one person. Okay, that's pretty typical. People like us have been around for about 35, 40 years, but we're still not a household term. Basically, a geriatric care manager is somebody with a background in healthcare, mental health care, working with older adults. And we serve as guides to clients and families who are feeling overwhelmed or don't know where to start when it comes to long-term care. And we do a lot of healthcare advocacy is one of our big goals. So working with a client who's in the hospital or in a nursing home or in the ER or a doctor's appointment, making sure that that person feels like their questions are being answered and that they know what the doctor can do that for yourself and for your loved ones. Okay, so this is our outline for today. I'm going to talk for about 30 minutes, so this is going to be short and sweet. There will be an opportunity to ask questions after the fact, so please write down your questions and we can do those once we get through this material. We're going to quickly review common health conditions facing all of us as we get older. Then we're going to talk about why are we here talking about the sea of options and navigating the healthcare system? Why is this even an issue? We're going to review the levels of care in the healthcare system and the long-term care system. And then we're going to focus on 3 settings where I, as a care manager, have seen a lot of issues for patients and people in these settings, in a doctor's appointment, in a hospital stay, and in a skilled nursing stay. Things that you need to be aware of so that if you find yourself needing to advocate for yourself or someone you care about, that you're going to have sort of a heads up, like, oh yeah, I heard about that whole admission versus observation issue. So I know I need to do something here. So you can come back and look at your notes. And then, like I said, we'll have questions. Sound good? Okay. More than half of us are going to need some kind of assistance as we age. And to me, that's good news because back in the 60s and before, people didn't live as long as they do now, right? I mean, does anyone know what the average life expectancy is right now? in the United
83.
States. Average is 79. So men and women average. So, you know, when you think about your parents, your grandparents, your great grandparents, people didn't need to think about long-term care, quite frankly, because people died younger. So we're lucky that we have the chance to live a longer life, but it also means that we're living longer with disability. And so that means we need to plan, right? So common conditions, cardiac, heart conditions, incontinence, arthritis, osteoporosis, cancer. A lot of older people do end up hospitalized due to pneumonia or flu symptoms. And then we have depression, dementia, the 3 Ds, depression, dementia, diabetes, and accidents and falls. These are some of the primary issues that lead us as we get older into the healthcare system. Now, some of these conditions are what would be considered chronic, and a lot of what a person can do to avoid ending up in the hospital is to be proactive in managing these conditions, like diabetes, for example, or osteoporosis. There's things that we can do proactively to help. Other times, things are unexpected, such as cancer or a pneumonia. So, you know, these are just kind of some of the things that we can expect as we get older. And if you know your family history, of course, and in consultation with your physician, hopefully you understand what your potential risk might be for some of these issues. And that helps you. If we know that and can sort of face that, then we can be in a better position to plan. And forgive me in advance because I use a lot of corny nautical metaphors in this presentation. So we're in the sea of options, and now we're going to enter some choppy waters. Okay? So why are we having this conversation about navigating? Why is that important? It's important because our healthcare system is fragmented. Sometimes the term silos of care is used to describe what goes on in our healthcare system. And basically what that means is if you go from one level of care to another, it is quite possible that all the information from that first level of care is not necessarily going to make it to the second level. And if it does make it, most likely you're going to have to do some interpretation for those new providers because they're just getting to know you. And this, I give one example here, and this is actually a very common scenario of the clients we work with. If they are hospitalized, let's say for a fall, which is very common, well, let's start actually at the outpatient visit. So they might be seeing a primary care physician on a regular basis. Let's hope so. We have some clients who, when we get involved, they have not seen a doctor for decades. So that's obviously an important thing to be proactive, is to see your doctor. But you may also have specialists involved, right? So let's say you have diabetes, you probably see an endocrinologist. Or if you have arthritis, you probably have a rheumatologist. You might have a cardiologist, a urologist. There's a lot of ologists out there, right? So those people, your primary care doctor and the specialist, might be communicating regularly, but frequently they are not. And that's shocking when I say that sometimes. People really do expect that all these people are coordinating. Sometimes they are, if they're in the same healthcare system, but sometimes people may not be in the same healthcare system, or the system isn't set up for them to get and exchange information easily. Let's say you're now hospitalized because you fell and broke a hip. You're going to be seen by a hospitalist in the hospital. That's a physician who specializes in caring for people in the hospital setting. And it used to be, back in the day, that a lot of times a family doctor would have privileges and would go see his patients in the hospital. That is less and less common now. And there's pros and cons to the hospitalist model, but this is the prevalent model. So you're in the hospital now, you've got your surgeon, if you need to have surgery, you've got the hospitalist who's directing your care. Primary care physician? No, by and large they are not. And maybe not the specialist either, because they're dealing with the here and now and what they're seeing in the labs and what has to happen, right at this moment. You might be discharged to skilled nursing. We're going to talk about that later. But that means you're getting rehabilitation, physical therapy, occupational therapies, possibly speech therapy, depending on the situation. That's a handoff, right, from the hospital to the skilled nursing facility. Information does get lost, right? And then you have to kind of re-explain to everybody how you like to be taken care of. When you like to take your shower, what you like to eat, if you have any allergies. These are things that you're going to have to say again many times. If you're discharged to home, now you're meeting your home health nurse and all of your home health staff. And then if you bring in private caregivers, let's say through an agency, you're going to be, again, explaining your needs and preferences to a company like ours. So you can see that even just one episode, like a broken hip, you could end up with all of these people, all these different teams, and a lot of different transitions where information can get lost. Okay, so let's just briefly go through the levels of care when we talk about the healthcare system and the long-term care system. And this is kind of broad strokes, but just to give you some terminology. So there's outpatient services, emergency department is the term more frequently used now, and urgent care. We've got outpatient care, which is when you go to see your doctor or your nurse practitioner. We've got inpatient or acute care, that's when you're in the hospital. Then we have skilled nursing, also known as a nursing home, a rehab center. And then we have home health care, which is delivered in the home setting for people who are homebound. And then hospice, which is end-of-life care. That's the medical healthcare system. Then we have the long-term care system. And this gets into for people who are older or who are disabled and need more long-term assistance with support with their activities of daily living, ADLs. You're going to hear that term a lot in the long-term care system. That refers to how much help you need getting in and out of bed or brushing your teeth, using the toilet, taking a shower, activities of daily living. So in the long-term care system, we have skilled nursing, which can transition into custodial care. Okay, so Medicare does have a benefit for people who are getting skilled nursing services in a nursing home setting. But at a certain point, Medicare stops paying, and now you're looking at long-term custodial care, which for most people in California is paid for by Medi-Cal. Okay, so you may choose to engage an aging life care manager. That would be part of your long-term care plan. You might have in-home care with caregivers. Incidentally, one of the big misconceptions I think that people have about long-term care is that Medicare is going to pay for whatever you need. And unfortunately, that is not the case, especially when it comes to this custodial care, meaning you need it just on a day-to-day basis to get by. It's not considered medically necessary, which is kind of crazy, but it's not covered under health insurance, in other words. Residential care facilities for the elderly is the official term for assisted living. And this level of care is governed by the Department of Social Services in the state of California, not the Department of Public Health. That's who oversees skilled nursing facilities. And memory care, as Alex was talking about earlier, is also licensed as residential care for the elderly. So also licensed and considered a type of assisted living. And then independent living means we have a lot of places here in San Diego where you can move if you're feeling pretty good and you just don't want to deal with your house anymore, or maybe you like to be around peers, do fun things, have a robust social calendar. That's an option. And then, as I said, dementia care, there are communities that are 100% dementia care. Many options actually here in San Diego because there's an increasing need for that type of care. And the staff there are specifically trained to work with people with dementia, to provide appropriate activities and deal with dementia-related behaviors. So that's a lot of information. I realize that. And like I said, if you do have questions about this, just jot them down and we can cover them at the end. All right, so how do we navigate these levels of care? And we could literally talk all day about all these different levels. So what I tried to do for today is really just focus on 3 levels of care where I have seen over the years there can be a lot of challenges for people as they get older, especially if they, because of memory loss or just inexperience, don't feel comfortable advocating for themselves, or they don't have a family member who's an advocate or a friend. So we're going to start with an outpatient doctor visit. One of the key things that you can do to have successful outpatient care is to communicate with your physician. And that means keeping track yourself of important events in your health. Not only immunizations, which luckily now you can basically download from, if you have an electronic medical record, which most of us do at this point. That's a great tool because you can go in there and print out when you had all of your shots. Okay, you can print out, every time you went to urgent care, it's going to show up in there. So it's important that you remember all of these things and that you can communicate intelligently with your physician around your own personal health history. If you're taking care of someone else and you are the advocate for them, sometimes it can be hard to have certain conversations in front of the doctor. Has anyone had that experience where there's things that you want to say, but you don't want to upset the person you're taking care of? This is a common thing when we're taking care of somebody with mild cognitive impairment or Alzheimer's or other types of dementia. So even though faxes are kind of dinosaurs in this day and age, faxing can be a really useful tool where you can get those questions to the doctor ahead of time. He or she can review them and sort of have that information outside of the appointment. And then doctors don't have a lot of time, right? Unfortunately. So one of the best things you can do is come with your questions very clearly distilled down to the key information and hand them to them in writing. I have seen doctor appointments go so much more smoothly because the physician can succinctly read a succinct question from you so they're prepared to answer. A lot of us, when we're under stress, we tend to tell long stories and kind of, include a lot of details. And so the physician's trying to figure out, what are you asking me? So if we can do that work ahead of time, it helps. Having a healthcare advance directive, super important part of planning. And so when you are doing your financial planning, please pay as much attention to your healthcare planning. And there's some great tools out there. I'd be happy to email you. There's State of California has some forms that you can use. Anybody can download them. Working with an attorney who's doing a comprehensive estate plan, they will typically do a healthcare advance directive and HIPAA forms with you. Beers list, basically, this is a reference, senior care pharmacist and Beers list and polypharmacy. All of this relates to the fact that as we get older, many people are taking a long list of medications. So it's important that you know there are some medications that are not indicated for people as they get older. Drugs, and they're some of the more common drugs that you might know of in that class are Tylenol PM, for example, and Benadryl. So a lot of older people have these things in their medicine cabinet, and they don't realize that these things can be linked to negative health effects for them. So you can look that up. You can Google Beer's list, and this is a list that's maintained by a physician group. I'm not remembering which one right now, but it basically tells you, what you should be on the lookout for. And a senior care pharmacist can review your medication list or the one that of the person you're caring for and tell you if there are potential drug interactions you should be aware of, or what could be eliminated. Because really the goal is to take as few medications as possible. And that can quickly spiral out of control when people take one medication, it has side effects. Then they're prescribed another medication to manage those side effects. It causes its own side effects, and so on and so on. And last but not least, you might consider, if you have the means, to work with a concierge physician, because they are set up to spend more time with their patients. They have a specialized practice where they are available to you 24/7 as far as phone contact, or sometimes they will come to the hospital to see you. So it's kind of harkens back to the days of the family doctor years gone by. It's a personalized approach to medicine. Not everyone can afford it, but if you can, it's something to look into. Okay, hospital stays. This is another area where chaos can break out because people find themselves in the hospital without warning sometimes, and it's very hard to be your own advocate, right? When you're in pain, maybe you're under anesthesia or coming out of anesthesia, or you're just disoriented because now you're in this new environment. It's noisy. People are asking you a million questions, poking and prodding you. So as much as you can appoint an advocate in advance as somebody who will be there to help you in this situation, it's going to go more smoothly. And that is typically a family member, but it could be a friend, it could be an aging life care manager, somebody who knows you, knows what you want to happen because you've written it down in your healthcare advance directive and you've talked to them about it. And they know kind of key information about you, like allergies is a huge one that sadly can be missed in the hospital setting. They don't know you have a latex allergy or a sulfa drug allergy, for example. Okay, so some common pitfalls is if you haven't done an advance directive, or they just don't have it, so you need to get that to your doctor and ideally to the hospital that you're most likely to frequent. There's a trend happening where people are not actually admitted to the hospital. They are brought in under observation status. Why is this important? It's important to know because if you are in the hospital and spend the night, you may find out later that you were actually under observation, not admitted. And that is relevant if you go on to skilled nursing, because Medicare has certain guidelines that if you are not in the hospital for a certain amount of time, then the skilled nursing stay is not going to be covered by Medicare. And that is a very rude awakening for people to find that out after the fact. Now they have a huge skilled nursing bill that they weren't expecting. And I'm happy to talk to you. It's a complicated thing, and I'm happy to talk to you more afterwards if you have questions about that. You definitely want to confirm emergency contact info in the hospital. We've had situations where a client has lived in La Jolla, let's say, for 45 years, and they've gone to the same hospital. But the contact information on file, these people are deceased, you know, no longer in their life or they've died. So the hospital has no idea who they're supposed to call if they need to take direction from someone. So make sure that that information is updated. And then as much as you can, try to get information directly from the physician. They typically make their rounds in the early morning or sometimes later in the day. So if you can find out from the nurses when does the physician do his or her rounds, then you can try to be there and ask those questions directly of the physician. It's very frustrating when you're trying to figure out what should we be doing next and you can't, you know, have that direct communication with the physician. Okay. Just a few words about discharge. Hospital discharges happen very quickly, and it's to your advantage if you can, as soon as your loved one goes in the hospital, let's say, is to assume that they're going to try to discharge that person as soon as possible. A lot of families are completely shocked when they hear, well, your husband or your wife, they're leaving tonight, and they do discharge people at night, like in the middle of the night sometimes. So just don't be caught flat-footed. You know, be thinking ahead. What is the plan? Are they going to come home? What do I need to support them at home? Are they going to go to a nursing home? Where do I need to go visit? So I'm not confronted with a list. Oh, these 3 places have beds available. Which one do you want? You need to decide now because they're going to be leaving in a few hours. So this is real. So as best you can, ask the hospital staff, ask the discharge planner, when is my loved one likely to be discharged? Because I need to get on this right now and figure out the next step. Okay, so that's where doing your homework comes in. You can ask for referrals for supportive care once that person leaves the hospital. Okay, they may not bring it up with you, but you can ask. In fact, with hospice, frequently physicians are very reticent to bring up hospice. And so many people do not get the benefit of hospice care until they are very near death, when in fact they could have been eligible much earlier and gotten a lot of supportive services. But the doctor didn't feel comfortable bringing it up. Okay, and then very importantly, know your rights. I brought some materials here on the table about one of the handouts is about appealing a hospital discharge decision. You can say, I don't think I should be discharged right now. I would like to appeal that decision. And you have that right to do that as a patient. And the hospital is required to give you paperwork on how to do that. Okay, but there's a little article here that you can review on that subject. The last setting we're going to talk about is skilled nursing. And this is, again, sometimes referred to as a nursing home or a rehab center. These facilities offer different types of skilled therapies, like physical therapy, occupational therapy, speech, IV. A lot of times people need IV antibiotics, and that is much more easily done in this setting versus at home. Or they might have wound care that requires special wound care nursing or equipment. Okay, so Medicare calls these skilled needs. Medicare will pay up to 100 days. If you, they pay a percentage for the last 80 days, and you also have to continue to qualify under Medicare guidelines. So it's not an automatic 100 days, just to be clear. You have to continue to need skilled nursing services. There is a big advocacy issue in this setting, which is that patients are frequently told, well, you're no longer meeting Medicare guidelines because you have hit a plateau with your therapy. Basically, you've slowed down or you're no longer progressing. I have some handouts here on this whole subject, which is a really big problem because most people, when they hear we're going to discharge you, you're not making progress, they say, okay, and they start planning for the next step. But you do have rights here. You can appeal a skilled nursing discharge. If you need to go on Medi-Cal, you have rights as a person who situation. Okay, there are ways to choose a nursing home using objective data, which I highly encourage. Don't go by, the wallpaper or the carpet, or if your friend's neighbor's aunt went to that nursing home. Because really what you want to know is, how is the care, right? And that is measured in various ways. So Medicare has a 5-star rating program. You can access that on the Medicare website. There's another great website called Cal Quality Care that rates nursing homes as good, fair, poor. So that's a good starting place. And then Department of Public Health, you can actually go online and look at the citation reports. What kind of citations did that facility get? Was it that the hot water heater was too hot, or was it that somebody died as a result of neglect? These are important things to know. And then just again, understanding the financial side of this. What am I going to be responsible for out of pocket? And what will my long-term care insurance cover? Because different policies cover different things. It's really important to understand, does your policy cover in-home care and assisted living and skilled nursing, or some mix of those? And then, as I said, you do have rights as a consumer in a nursing home setting. There is an ombudsman, an 800 number that you can call if you have any kind of concern or complaint. It's their job to resolve that with you and the nursing home staff. And California Advocates for Nursing Home Reform, there's the nonprofit that published some of this material, has some wonderful resources, like a checklist when you're choosing a nursing home. And if you do need to file an appeal, they have sort of step-by-step directions on how to do that. All right. And the state medical board, you can look up any physician and see if they are licensed, which, that is, it would be very unlikely that someone wouldn't be licensed in this kind of setting. But you can find out if someone's on probation, because people can still practice as a physician even when they're on probation. There's a really great Consumer Reports article on that subject, which is totally floor you if you read it. But all doctors are not created equal. Let's just leave it at that. Okay. And then there are care conferences in rehab. So get to know that staff and when those meetings are so you can participate. And then just like anything else, the people taking care of you or your loved one are people, right? And they have a hard job. So as much as you can get to know them, get to know their names, they're going to treat you the way that you treat them. And so just being kind and collaborative with your staff is going to benefit you in the end. And don't be afraid to speak up. It's documented that people who have visitors and family members coming to nursing homes to visit them, they get better quicker, they get better care, and they're less likely to be victims of abuse or neglect because their advocate is coming in and the staff knows that. Okay. And then especially if your loved one has dementia and is living in a nursing facility long term, you want to personalize their room as much as possible. And that helps their mental health, but it also helps the staff to see them as a person with a history, with family, with interests. And that's extremely important, again, for their quality of care. And finally, I would say just because someone's in a nursing facility, even long term, that doesn't mean they don't still enjoy doing, things that were interests before or new interests. So get them out of the room, get them engaged in activities, wheel them outside so they can be in nature for a while. All those little things really add up in terms of quality of life. Okay, so we're at the home stretch here. Just to summarize, we talked about the healthcare system being fragmented. which means you need to be your own advocate and to appoint someone else in the event that you cannot make your wishes known. That means writing it down in an advance directive and talking to that person to make sure that they are willing to act as your advocate. Start planning. If you're admitted to the hospital, know that you're not going to be there for a long time, most likely. So start thinking about what is the next step. Don't assume your healthcare professionals are talking to each other. Everyone is under great stress, time-wise, financially, a lot of people to take care of in a short amount of time. Okay, so you're going to have to bridge those gaps, or your advocate is, when you go from one level to another. Know the options in your community. Okay, which 3 nursing homes would you want to be in if it came to that? Or work with a professional who's well-versed, in those options and can narrow that list down for you very quickly. Okay, and then just know when you're choosing a facility, whether it's assisted living or skilled nursing, you should choose wisely and not just go by physical appearance of the place, and know that you have rights in any setting. If we can be of service to you, Katie and I are available after this presentation, and also you can email us later or check out our website. We're happy to assist you. Thank you very much for your attention.
Very good. And so you guys laid out materials here in the middle too that people can take as well. So perfect. Was that good? Yeah. You guys learned a lot? Excellent. Very good. So I'm glad you learned a lot. I think it's just an important piece, knowing that, again, we are all experts in different areas of our lives, and we need to coordinate these experts holistically. So for those of you that are clients, I'm sure you've seen these types of graphs before. But this is really common for people as we're working through retirement and thinking about planning and long-term scenarios and going, okay, these blue bars are my assets, and as I continue through retirement, I'm going to be drawing down. I have to meet my needs. But what you'll notice is that we leave ourselves very little cushion here. Right? So what happens if we have a healthcare event? And so I think one of the biggest fears around healthcare events is that it's unknown. Right? We don't know exactly what it's going to look like, and that's what's scary. But what can help is if we start to model, okay, if I do experience a long-term care event, or if I do need care, and we start to estimate what those costs might be, how would this actually look in my plan, right? What can we be doing today to be planning for those types of impacts? And so you can see like some small tweaks in the plan, whether it's, I make sure that my policy is up to date, I have an adequate amount of insurance, or that it supplements my coverage, right? Do I have the proper team in place? Because as Susan has noted here, it's not just about having all the money to pay for it, but it's knowing who to talk to, right? Because you might run into a scenario in which you need to make sure that you're discharged at a proper time or at a later date, otherwise you're left with a hefty bill, right? Which will ultimately impact your plan. So it's not just about having this big nest egg to protect yourself with. It's navigating the system effectively to actually reduce costs overall. Right. So actually, I was going to talk to you guys about this real quick. I don't know if you're ever, okay, so this is actually a great tool, and it's a free tool that you can use. Again, this paints with a broad stroke, so take it with a grain of salt. But if you actually Google just Genworth cost of care, we use it frequently, and what I like about it is that you can search for care in your specific area. So costs of care are different in Middle America than it is in San Diego right on the coast, right? It's much more expensive out here. And so you can get a feel of what those costs are, and they'll break down things like, okay, here's how much it costs for in-home care. Here's how much it costs for assisted living, all the way up to nursing home, because it can break down even more granular in terms of, let me see if I can zoom this in for you a little bit. Because there's a difference between a semi-private room and a private room, right? Those costs have an impact, and those costs can be substantial. And the other thing too, as we know we have to be careful of, is the costs of healthcare are going up pretty fast. I mean, since 2018 until 2019, the cost for a semi-private room increased about 10% in San Diego. Right? These costs are only going up and only increasing rapidly. So again, really nice tool to use. Take it with a grain of salt. It's a big, broad brush stroke, but this gives you a good starting point for what this cost can look like, and it's a good conversation starter. So thank you all for attending. Glad you learned a lot, and again, Susan and her team will be here afterward to answer any of your questions. And thanks for coming.
I have one big question that may